Hi, everybody. My name is Michelle Adzhemyan, and I am here to talk to you about the Quality and Performance Improvement section of the Board of Governors exam. One of the more fun sections, in my opinion. It is probably on the middle end of size in terms of the different sections of the exam. It's 20 questions or 10% of the exam. You can see here through this list what types of topics it covers. You can see benchmarking, medical staff peer review, risk management, performance improvement, customer satisfaction, utilization review. All of those are things that we're going to touch on today. A little bit about me. I work for the Southeast Permanente Medical Group. We work with Kaiser Permanente, and I'm the Director of Strategy Acceleration and Care Transformation. My background is in Lean Six Sigma and innovation in human-centered design. I have been in Georgia for 5 years. Before that, I worked for a number of large healthcare systems in California that you can see listed on the screen. I got my FACHE certification in 2013, so I may be a little bit rusty, but I have taught this class for many years now, so I tend to stay up on these things, or at least I try to. As it says below, I think I've been teaching this class now for maybe 7 years. So I'm very excited to talk to you today. I wish it could be in person because I very much like to have more of a dialogue-based presentation versus me just talking all the time, but it is what it is. So I'm going to do my best to make it interesting for you today. Here's what we're going to talk about. We're going to spend a lot of time talking about lean, PDCA, process improvement, and then some of these other topics that we mentioned earlier. And we are not going to do the practice exam questions because you're going to be doing those in the live classes. I think this is a really great quote. I'll read it for you. What determines how great a healthcare organization will become is how well its leadership creates a culture of excellence and safety, improves the enterprise system, and effectively implements best practices. And I firmly believe in that. We need to create an excellent, safe environment and embed that mindset in our cultures in order to be successful in healthcare. You may have heard of the Institute of Medicine. There was a report written about 20 years ago called Crossing the Quality Chasm. And in that report, they wrote a 6-part definition of healthcare quality. And you can see it on the screen here. You probably want to remember these for the test. And again, what I'm going to be doing throughout this, if I remember something as having been on the exam when I took it 8 years ago, I'm going to call that out so that you're paying attention to those things. So I think this is one of those that's very good to know. Here at Kaiser Permanente, our quality leads use this all the time. In fact, we anchor a lot of what we do around STEEP. So we call it STEEEP. But we are always looking at these, and I imagine many of your organizations are as well. Quality improvement consists of the processes and tools that we need to continuously improve quality of services. You may have heard of other statements like CQI, TQM, Six Sigma, but they're all built on the foundation of customer requirements and statistics. And really, you need support from the top down, but it really needs to be about the frontline employee participation if you're going to be successful in any quality effort. That's my strong belief, and I think that it's one shared by many in healthcare. Very simply, we strive to reduce, if not eliminate, and prevent defects in healthcare, and those will decrease costs, enhance the work environment, reduce errors, and all sorts of other great things. I mentioned all of this a little bit earlier. I don't want to go into this too much. I think what's important to call out here is that there is an interconnectivity of processes and systems. So if you make changes to one part of the system, you need to make changes to the next part. And in fact, we look at balancing metrics in my line of work because we know if we make changes to one part of the process, there are going to be upstream or downstream effects. We want to make sure that we're not negatively impacting other parts of the process. This third bullet I think is really important. Better decisions are made when they're based on data, not on intuition. When empowering stakeholders and staff front lines, like I mentioned, and managers need to relinquish unilateral decision making. Quality is best served when we are collaboratively working on things together. And there are a lot of different tools that can be used in the quality space, and I'll talk about some of those in a little bit. What I think is important to keep in mind here is that you do have customers and suppliers in every step of the process, and keep that in mind. And your customers may not always be your patients. They may be other employees that are helping to deliver the care to patients. Processes should be mapped and defined step by step so you can really understand how they're working and where they may be deviating from where they need to be. This third one I think is pretty important. I think it's important for you to know for the exam that quality improvement is continuous. So if you achieve your target, you're not just going to stop and walk away and say, hey, we've done this, we never need to look at it again. You need to continually monitor things. And maybe you're successful in one area, well, then take that success to another area. Or perhaps what you do is you continuously monitor once you've hit your target to make sure that you're not falling off, because that can happen. And then variation, all of this is subject to variation. And really in healthcare, we want to minimize variation as much as possible. You can see the evolution of quality. It's been part of healthcare for over 1,000 years. Really, performance improvement is kind of where it's been for the last 20 or 30 years. I would argue that human-centered design is maybe the next phase. We're doing a lot of human-centered design type work in healthcare these days. A couple of these are important to know. Really, quality is about evidence-based medicine. We don't practice medicine based on what we think is best. We look at what has been proven and really trying to spread that. And then in terms of Malcolm Baldrige, those are criteria used for performance excellence. And for a long time, there were no healthcare organizations that got this certification, but now it's becoming more commonplace. Six Sigma, this is near and dear to my heart. In the Six Sigma world, it's all about achieving Six Sigma, or getting no more than 3.4 defects per million opportunities. And it has been used in healthcare for a while now. It can be very hard to get to Six Sigma in healthcare. Other industries really strive for that, like the airline industry. If they weren't Six Sigma, people probably wouldn't be flying. Think of how many millions of customers they have flying a day. If 3.4 out of a million customers was in an airplane accident, that business would not survive. So we want to try to get there in healthcare. It's not always possible because people are very different, but it's possible in some circumstances. And then in the Six Sigma method, we use the DMAIC approach. You can see the definition on the screen there. PDCA, you may also know this as PDSA. It stands for Plan, Do, Check Act or Plan, Do, Study Act. They will ask about this on the test for sure. So make sure you're familiar with it, and we're going to talk about it a little bit more later. It is also known as the Shewhart model of improvement. So PDCA, PDSA, Shewhart model are all the same thing. What is lean? Again, near and dear to my heart. It's a systematic approach to identify and eliminate waste or non-value add activities through continuous improvement and participation, again, of all employees. If you take one thing away from this, take away that you need your front lines involved in this type of work. It's all about defect-free work with no waste, and providing the right products or services the right time, and doing what the customer needs the right way. Value added and waste. So we talk about value add from the customer perspective. So think about all of the things that your customer does. And, if we were in person, I would do an exercise around this. But if you think about all the steps that you take to go see your doctor, how many of those are actually a value add for our patients? Is having them sign in 2 or 3 different times a value add? It might be to us so that we can ensure that it's the right person that we're seeing, but it's probably not a value add to our customer. When we talk about non-value add or waste, I like to teach the acronym TRIMWOOD, which you can see on the screen. I've heard at least 3 or 4 other different acronyms to describe the types of waste in healthcare. So keep these in mind. I think waiting is the #1 waste in healthcare. Technology isn't the solution. I'm sure all of you have lived through migrations to electronic medical records. Has that made all your problems go away? No. Sometimes it gives you more problems because as people get used to the system, they do things that they didn't intend to. So just keep that in mind. Orderly processes, when there's an environment of disorder, will still be subject to errors. So we've got to really work on those. And again, technology will not solve all of our problems. Here we come back to the shoe heart cycle. I guess there's another name for it, the Deming wheel. So now you've got 4. Fun party trick there in case you ever need it. So it's all about plan, do, check, and act. So planning is really problem identification and understanding of your current process and defining what the problem is and setting measurable goals. Doing is actually trying it out. Select a solution and act on it. So really a lot of, I think the most important piece of this is do, actually like putting something out there. But then you've also got to check or study, analyze the results, and then act. What did you learn? Are you going to adapt, adopt, or abandon that solution based on what you learned from it? So, one thing that I think is the most important thing about all of this is really making sure that before you go into before you go into do, you decide what success looks like. And so if you don't hit that success mark, you need to check it, and then you need to act. Maybe you don't adopt it. And in fact, I've done pilots in my career where we have not hit the target that we set out to achieve in our PDCA process. And so our acting was to abandon the solution altogether. And then we went and found something that worked better for us. So that's a really important part of this whole piece. The value equation of healthcare. I think that this is probably important to know as well. Value equals quality divided by cost. If there are 2 healthcare organizations and they offer equal quality, but one is cheaper than the other, that one is providing more value. If there are 2 organizations that have the same cost structure, but one has better quality, they are offering better value. So we talk about Kano here. I'll talk about him more in a second. But really, there are a couple different ways that you can improve the quality. You can either eliminate the problems because the customer expectations are not met. Quality problems, try to eliminate them. Or you can reduce cost. So this is how you can affect the equation. You can either eliminate quality problems, so thereby increasing quality. You can reduce cost, so that denominator, you can make a change there. Or you can expand their expectations by providing services that are really high in value. This is the Kano model. I can't recall if this was on the test. It might be. I think there are a few important points about this. I want to explain them to you. So there are threshold attributes, performance attributes, and excitement attributes. And you can see the continuum here, the product function, whether it's been fully implemented or not, versus customer satisfaction, low or high. And I'm really going to focus on the customer satisfaction part of it. A threshold attribute can also be thought of as like a pay to play. When you're thinking about cars, I would argue that air conditioning is a threshold attribute. I don't think anybody's going to buy a car these days if it doesn't have air conditioning. Certainly not in Atlanta, right? Then you have your performance attributes. So you think of those things in a car where, hey, this is kind of expected these days. You need it to get around. You might have cruise control as an example of a performance attribute. You might have ability to connect with Apple, Apple and Android devices. You might have heated seats, maybe as a performance attribute. And then you have excitement attributes. Those are those things that are new and crazy and nobody expects them to be in a car, but they are. We just bought a Kia Telluride about 2 years ago, and maybe the number of chargers, the USB chargers, that charging options that were in the car, that was an excitement attribute to us. We weren't expecting that. Although our car doesn't have this feature, when you wave your foot underneath the bottom of the car and it opens your trunk for you, hands-free opening, that's an excitement attribute. I think what's important to know about this is over time, things that used to be excitement attributes and performance attributes eventually become threshold attributes. So probably 30, 40 years ago, maybe 60 years ago, air conditioning was an excitement attribute. Today it's a threshold attribute. So keep that relationship in mind. In terms of the process improvement toolkit, this is a Gantt chart. They do ask about this on the exam from what I remember. This is a list of activities needed. That's an action plan. So an action plan is the list of activities. The Gantt chart is the visual mapping of all of the steps that you need to do in a process. And a Gantt chart is always shown over time. So you can see, in May, they started validation sessions. In and then shortly after they started clinical content design. So you can see the relationship over time, where you are in this picture and how things work. We use these all the time in my line of work. But what's important to know is that the Gantt chart is a visual tool that tracks progress against your plan. So make sure you know that. In terms of a flow chart and value stream map, it's a graphic representation of the sequence of steps performed in producing some output. And I think that this picture here is really important. A lot of times when you're mapping the current state, people map what it should be. And that is not what you want, because you're never going to be able to improve if you don't understand the deviations from what it actually is. So what you want to ensure is being done is you're mapping what is actually happening, even if a lot of bad things are happening, even if it's deviating from what is intended. It's really important to map it the way that it currently is. It's a very, very effective tool, in my opinion. And I also call it the AHA tool, because it's good to get people from different departments in the room mapping out the same process, because they'll say, aha, that's why you do it that way. I always thought you were being lazy, or I always thought this, but now I know, and now it makes sense. And it can actually bring teams closer together. So it's one of my favorite tools, although it can be challenging to facilitate at times. There's also the value stream map. The difference between the value stream map and the process map that you just saw is really you're looking, you're timing things, and you're seeing kind of the boxes with the statements and sequences underneath. There are a few more nuances with the value stream map. Usually, although this one doesn't have it, usually you're adding in time components and you're timing the value add and non-value add time. This one doesn't have that, but that is pretty standard in a value stream map. So you might want to know those differences a little bit better. Here's how you draw a process map. You define your start point and your end point, and then you figure out, you get the staff, again, coming back to the front lines to engage in the work. You list the process steps, the key milestones across the top. I don't typically do that. That's a little bit unique. And then you identify the opportunities for improvement. Where are we doing things one way, but we could be doing them differently? And what you see here is a swim lane process map. So a swim lane process map is organized in different horizontal lines like this, based on functionality or the person doing the work. This is a control chart. It's a quantitative display tool to track performance over time by studying process variation. What's important to know about control charts is that control limits are established by the process. So as you continue to add data points, the control limits will change, because they are calculated based on the data that is entered. And control limits are usually set at 3 standard deviations above and below the mean. So anything that falls above that upper control limit or below that lower control limit usually means that there's special cause variation or something out of the usual is happening. And so that's something you usually want to study. This is a real life example from a black belt that I had mentored. He was working on % of patients who left the hospital without being registered in the emergency department. And you can see that towards the end of his project here, or at the beginning, there were a lot of points that were above the upper control limit. So some crazy stuff happening, a lot of people leaving when they shouldn't have been. And then you see over time that it went down and actually hit the lower control limit. And sometimes when you're looking for meaningful statistical change, you actually want it to go below the lower control limit or above the upper control limit, depending on what you're measuring. In this case, this was great. They did improve. So the changes that he implemented were effective. This is a fishbone diagram, also known as an Ishikawa diagram. It's kind of, or a cause and effect analysis. So this one has a few different names too. This helps you to organize and display various ideas for the potential causes of a problem. So in the fish head, or the part on the far right, you're going to put the problem that you're studying. And then you can either pre-populate it with topics like these listed on the screen, or you can just come up with your own categories. For instance, why do we have so many patients leaving without being registered? Well, it might be due to machine. Maybe there are some computer issues that prevent patients from being registered right away, and they're sick of waiting, and so they leave. Manpower, maybe we don't have enough staff to tend to all of the patients who come in. So you really want to drill down to those issues that you think are true root causes, where you can't drill down anymore, and those are what you want to target solutions towards. Modeling. This is a tricky one. There is going to be a question about this on the test most likely, and I unfortunately have never really encountered these in my career. So I'm going to do my best here. I'm going to encourage you to look them up and study them on your own. I know Rahul also has some thoughts on these, so he can explain these better than me. But a PERT chart is a program evaluation and review technique. It helps you to analyze the involved tasks in a given project and the time needed to complete each task. So it's really about timing and charting. Stochastic modeling, you present data or predict outcomes that take into account randomness or unpredictability. So it's modeling and presenting data. Monte Carlo simulation is a problem-solving technique. You use that to approximate the probability of certain outcomes by running multiple simulations using random variables. So stochastic modeling, so think of maybe a little bit about the difference between modeling and simulations. I have read in some places that Monte Carlo simulation is a form of stochastic modeling. So again, your head might spin as you research this. Sometimes it's okay to take a hit and lose one question on the exam, and that was kind of my approach with this category. But if you do want to know more, I think there are some good resources out there that can help you differentiate between these a little bit more. A histogram. This is a quantitative display tool. It summarizes data from a process that's been collected over a period of time. The one here is glucose test processing, total cycle time. So you can see that anything from 0 to roughly probably 60 minutes was in one bucket, and then 60 through maybe 95 was in that second bucket. They have 65 as the midpoint. This isn't really the best way to list one of these. I would actually do it a little bit differently. But the point is you're looking at frequency over time, or frequency based on a numerical continuum. That's what I would say. Sometimes it can be based on color too. What's your favorite color? You find that 104 people like blue, 379 like green, 143 is red, and so on and so forth. I mean, it can be that type of a metric as well. I think what's really, they will ask about this on the test, I think, the difference between a histogram and a Pareto chart. Make sure that you understand that. A Pareto chart, and I think we get into it in a little bit, but a Pareto chart, the bar on the left is always the highest, and then they go down in descending order. A histogram, that's not necessarily the case. It's usually not the case, in fact. So if you don't see it going down in descending order, you can already assume that it's a histogram. And here's the Pareto. It shows relative frequency or size in a bar graph, and you use this to really look at your most important issues. So it ranks the most important issues first, and then it goes down. So you put all of this into an analysis and then click a button and it'll calculate it for you. At this point, with left without being registered, continuing with the example from earlier, the number one reason was because they couldn't locate the patient within the FirstNet computer system. And then the second reason was the discharge RN did not direct the patient to the right area upon discharge. So because of these, those are the areas that you would then want to focus on if you were trying to solve this problem. You wouldn't want to focus on patient not directed to the certain area because that only happened once. So hopefully that makes sense. Also, if you've heard of Pareto, the concept comes from Vilfredo Pareto. He was an Italian economist, and he made the point that 80% of Italy's riches were owned by 20% of the population. So that 80-20 rule pattern tends to hold up in a lot of things in nature. So keep an eye on that. Once you know it, you see it a lot. Benchmarking. You're comparing yourself against best practices. There are lots of different types of benchmarks. There's internal benchmarking, comparing within your own organization. In Kaiser Permanente, our Georgia region might compare ourselves against one of our regions in California or one of our regions in Colorado. Or we might compare how we're doing on access versus our, one department might compare versus another within the same organization. Competitive benchmarking. This is where you compare your organization against your toughest and best competitor. That might be other healthcare systems in the Atlanta market in our case. Functional benchmarking. You might compare your organization to a world-class organization in the same industry. Mayo Clinic, Cleveland Clinic, Johns Hopkins. Those are examples of functional benchmarking that we may do. Generic benchmarking, compare yourself to a world-class organization not in the same industry. Maybe we compare ourselves to the aviation industry. Maybe we compare ourselves to the manufacturing industries. So those are some examples. So know the difference between these and know what benchmarking is about. I do believe that this will come up on your exam. And then we have different benchmarking companies. You can, HCAHPS. HCAHPS is an important one to know. They provide standardized surveys in hospitals, and you have to pass your HCAHPS exam every couple of years. I think they call them, I'm sorry, no, I'm confusing that with the Joint Commission. HCAHPS is a survey that patients fill out in the hospital, and it compares us against all other hospitals that are using that surveying format. You also have Press Ganey and Gallup in the patient, employee, and physician satisfaction space. And then the Leapfrog Consortium, they like to give grades. It's always fun to see where they end up grading you. And then we've got the Institute for Healthcare Improvement. It's a great organization that provides information. Quality assurance and risk management. You're supposed to monitor, control, and direct the institution's efforts toward achieving delivery of the optimal level of care. And you do want to have an in-house program. This is not something that you want to outsource. You have a governing body, and they asked a lot of questions about governing bodies on my exam, so just be mindful of that. So the governing bodies are responsible for establishing, maintaining, and supporting through the medical professional staff and management staff a program of review and evaluation, and you can see that here. And then coming back to continuous quality improvement, we mentioned that earlier, the status quo is not sufficient. There's a lot of public reporting, as we talked about a little bit earlier. I think a lot of organizations don't necessarily put a whole lot of stock in these because it can be outdated data, kind of subjective in some instances, but consumers are looking for this kind of information. So you do want to be, you do want to have a good face towards the, in the industry on these types of things. Quality focused organizations. So CMS, that you need to be in compliance with CMS, really to be in business as a hospital. Then you have the Joint Commission. That's what I was referring to earlier. Every 3 years, you get surveyed as a hospital, and they determine whether you can continue to operate and be a provider for CMS. And you have the Institute for Healthcare Improvement and the others that I mentioned earlier. The Joint Commission, National Patient Safety Goals. I do not want to spend a whole lot of time on these. They may have changed a little bit in the last few years, but what's important for you to know is that there are national patient safety goals that accredited organizations are supposed to be following. And some of them include making sure that you identify patients correctly, that you're using medicines safely, that you're using alarms safely. So those are important to know. And then there can be court outcomes as well that are measured in the quality space and making sure that organizations are performing well in these areas. So you can see those listed here. There are conditions of participation. If you're going to be a provider that takes payment from Medicare and Medicaid, you need to do certain things. You need to meet certain standards. So it talks about that here. And again, the Joint Commission can help to figure that out. And then also CMS will come in and do its own surveys on occasion. You can see some of the conditions of participation in the bullet points here. We talked about HCAHPS earlier. Maybe what I'll call out here is the focus areas: nursing care, physician care, hospital environment, hospital experience, leaving the hospital, overall rating, and understanding your care when you left. So those are important to do well in. Then in terms of the medical staff, self-governing, organized medical staff. I think that's important. A lot of times medical staff information is privileged, and so you don't want a lot of outsiders in those medical staff meetings. And then you are to maintain bylaws and hold your providers accountable to the bylaws. It creates a framework. Designated members of the organized medical staff can have independent privileges. And when you have independent privileges, you provide oversight of care, treatment, services by practitioners with privileges. The organized medical staff is accountable to the governing body. That's important to know. They ask a lot of nuanced questions about that from my recollection. And then medical staff and leadership. The hospital's governing body has the ultimate authority and responsibility for the healthcare rendered by licensed independent practitioners. So the governing board is accountable for the quality of care. That's important for you to know. And then there's credentialing and privileging and peer recommendation. So credentialing is all about verifying and assessing the qualifications of somebody who wants to provide care at your organization. Then privileging is actually giving them the permission or the privilege to provide a specific scope of care. So once you go through credentialing and it looks like they're okay, then you might extend privileging responsibilities to them. And then you have peer recommendations. So usually you need to be recommended by at least a few peers if you're going to be a provider at a certain facility. I'm not sure that there's a whole lot to call out here, except that the hospital management's responsible for systems performance improvement, and then the medical staff is for individual and aggregate physician performance improvement. There's peer review, morbidity and mortality. These are committees where you learn from complications and errors, and you're trying to modify behavior and judgment based on previous experiences. They're non-punitive. It's all about learning and understanding what went wrong and doing it differently next time. Peer review is a process by which a committee of physicians looks at the work of a peer and determines whether the physician under review has met accepted standards of care in rendering medical services. A sentinel event is something that's an unexpected occurrence. It is very severe in scope, and there's a big notification. You know, they signal the need for immediate investigation and response, and a lot of attention will be called to them. Then you do root cause analysis. You can use the fishbone diagram to help with root cause analysis, but you're really trying to understand why it happened and what systems and processes underlie those proximate factors. In terms of quality and reimbursement, a couple of things that are outlined here. Pay for performance. It's designed to offer financial incentives to physicians for meeting certain targets. Then transparency. You want you try to be transparent in healthcare because you want consumers to be able to compare the quality and price of healthcare services. So it's really important to be transparent, more so today than I think it ever has been in the past. Then you have the physician quality reporting system. It's an incentive payment for eligible professionals who satisfactorily report data. And then value-based purchasing. This was a really, I've been away from the hospital space for a couple of years now, but this was a really hot topic back in the day, where it was all about if you hit certain measures, you would be given an additional payment. And if you missed some of them, then you would have your funding reduced by the federal government. And, one of the hospitals I used to work at was hit with value-based purchasing before. So we had to give back some of the money, or not give back, but we lost a little bit of money because we weren't hitting the targets as well as some other organizations. Utilization review. This is the payer's opportunity to review a request for medical treatment to determine if it was appropriate. Most health plans have predetermined criteria or clinical guidelines for a given condition, and so that helps to make those decisions. And that is all I have to share with you today. I will be meeting with all of you in probably sometime in the coming weeks, and I look forward to answering your questions on this topic and helping you understand further. So sorry, it was maybe a little bit more stilted than I would have hoped. Hopefully this was beneficial to you. Thank you for your time.